All right, so I'd like to thank everyone for joining this meeting. I know that over time people will continue to trickle in. We're very glad to have Dr. Daneman, who is a professor of medical imaging at the University of Toronto and a specialist pediatric radiologist with us this afternoon or this evening. So I will be your moderator for the day. Just to get things going, I will have the president just say one or two words, and then I will give a short citation for Professor Daneman, and then we'll get into the lecture. Dr. Lanusi, please.
So good evening, everyone, and welcome to the July series of the July episode of the SPIN lecture series on pediatric imaging. I want to thank Professor Daneman for giving us his time. I know he's a very busy man, and we feel humbled having him here to teach us the basics of abdominal imaging in children. And I know this is going to be a beautiful lecture. I'd actually invited many of my friends, colleagues in pediatric emergency, and they're really looking forward to this lecture. So thank you so much, Professor, for giving us your time, and then welcome to everybody who is on this call. Thank you.
Thank you, Dr. Lanusi. So I'll just give a brief citation of Dr. Daneman. And I don't mean to exaggerate it, but he does have quite an impressive background. So, but to keep it short, Dr. Daneman has been at the hospital for sick children in Toronto since 1979 as a staff radiologist. I know that's before many, at least maybe a third of us were born on this platform now. And he was also radiologist in chief at Sick Kids from 1988 to 1995. He's one of us in that he's from Africa. He was born in South Africa. He's South African primarily. He attended the medical school. I may not pronounce this right, but University of Witwatersrand in South Africa, where he primarily trained in radiology, and then the University of Sydney in Australia. He was also a fellow in pediatric radiology at Sick Kids in the 70s. He's an honorary member of the European and Latin American Societies for Pediatric Radiology, of the Chilean Society for Pediatric Radiology, the Israeli Society for Pediatric Radiology, Hungarian, and a very long list. He's life member of the Royal College of the Royal Australian and New Zealand College of Radiologists, and he was awarded the gold medal of Brazilian College of Radiology. He has over 200 radiology publications in peer-reviewed journals. He has authored several book chapters in pediatric radiology. He has been an invited guest lecturer all over the world. He's gotten grant funding in the area of neonatal imaging, specifically necrotizing enterocolitis, to the tune of over $3 million. He's given lectures all around the world, as I said, and he's been an award winner for several things, including the Caffey and Kirkpatrick. He's given the Caffey and Kirkpatrick Memorial Lectures and has also received the Jack O. Hiller Award for Excellence in Teaching from the Society for Pediatric Radiology. If I were to go into all the little details from 79 till now, would probably use up all our time. So without keeping it to that, as short as I can, I would like to welcome Dr. Daneman for this talk on acute abdomen in neonates. It's a very germane topic, and I hope that we can all stay focused and get as much as we can from the talk. So Dr. Daneman, thank you.
Thank you very much, Rotimi. It's a pleasure to talk to you today. If I'd known that I was going to be giving this lecture before the final of the football game in Europe, I might have refused. But for you, I do anything. And it's been wonderful having you here in Toronto. And I'm sorry to see you go. And I'm sure we will keep contact and be friends for a long, long time. It's a pleasure and a privilege to speak to people in Nigeria. I thank everybody who's logged on to attend. This topic that I'm going to talk about, the acute abdomen in neonates, is one that I'm extremely interested and have been so for many years since I first started training in pediatric radiology. And I'll try and show you some interesting things that I think are important in this area. It can't be a complete lecture on everything related to the acute abdomen in neonates, but I will do what I can in the next 45 minutes. You'll see my first slide has 3 giraffes on it. I didn't pick this as a particularly African topic, but I've always lectured this topic with the giraffes, whoever I'm talking to.
I can see your screen.
Can everybody see the screen with the giraffes?
Yes, we can. Yes.
Excellent, excellent.
Yes.
So we'll talk about the giraffes. If I say anything that somebody does not agree with what I'm saying about the giraffes, please let me know on the email, because I'm always trying to get more information about giraffes. But what we're going to talk about on the neonates is, first of all, there are 2 basic abnormalities we think about in neonatal acute abdomen. One is obstruction, which can be congenital or acquired, mostly congenital. And the second one is ischemia, which is necrotizing enterocolitis, or NEC, or so-called idiopathic perforations. I want to emphasize that the modalities that we're talking about in these babies are pretty basic, simple, old modalities. Virtually all of these babies will have plain radiographs at the time they are considered to be ill. In the past, these were followed by contrast studies, usually rectal contrast enemas and sometimes oral contrast studies. But more and more in recent years, sonography has come to play a major role in these patients and can give us very useful information without having to use more radiation. First, I'll start off with talking about the importance of the intraluminal gas and the normal patterns in babies. You'll see on the right, on our left is a gasless abdomen. Here is just a little bit of gas in the stomach and proximal small bowel. Usually by the time one gets an X-ray on a normal baby, it will look like this. It's very uncommon to get a completely gasless abdomen, but I'll talk about that in a little while. So most abdomens, the normal ones, by the time we get an X-ray, even if it's fairly soon after birth, they'll look like this. And then the gas gets through the entire small and large bowel down to the rectum here. And you have this pattern of gas filling the entire abdomen in an AP supine and a lateral shoot-through view. And I think these are the 2 major views that we do on these babies. There are some areas in the world where they will omit this lateral shoot-through, but I will show you why the lateral shoot-through is so important. The bubbles of gas have a polygon-type appearance, and in the past, we used to say this was a mosaic appearance, but I've learned over the years that mosaics usually either have squares or rectangles, but these are polygons. And I found, this is where the giraffes come in, is that they correspond to the color patches on these giraffes. These are reticulated giraffes where the patches are right up against each other, and the lighter area is very, very thin. And this is how the bowel looks, at least to my eye, in these babies, these polygons that are right up against each other, squashing each other and deforming each other into different shapes. If you look at other modalities, sometimes even on an MR, you will see the small bowel like this. If you look carefully enough, you'll see the giraffe in there, just like I tend to see a giraffe pattern. So I like to use that as a way of explaining what the bowel should look like. When it gets obstructed or there's ischemia, you lose the polygon pattern, as I'll show you, and the loops look a lot more rounded and elongated. Now, it's very, very difficult, if not impossible, to differentiate small and large bowel when you get this pattern of gas throughout the bowel down to the rectum here. You can say this is the rectum with certainty, but the rest you don't know which is small bowel or large bowel. In this one, again, you don't know what's small bowel or large bowel. In this one, you can see there's a Hausdorff pattern in the transverse colon. That's helpful. But this happens to be in a cystogram, and it just happens to be in an abdominal X-ray where it's not going to help you very much, which is not comforting. This is probably the rectosigmoid region down here. In this one, you'd think that this over here was the transverse colon, but it in fact was just some proximal small bowel that was elongated and obstructed. The size of these polygons does not usually make a difference. There's an old saying that says size does not matter, but you can see the polygons here are quite large, and yet there's gas and stool in the rectum. This we find is most commonly seen in patients who have non-invasive ventilation like CPAP, if they've just been resuscitated with a mask. Sometimes premature babies have immature bowel, and similarly in small for gestational age, the premature bowel then dilates up. You can have plugs or an ileus. So the cause in these patients is usually due to one or a combination of the above. It's benign, doesn't require operative management, and usually it's transient, but it can sometimes be prolonged, and then it becomes worrying. But I think this is the most important thing, is the non-invasive ventilation, the positive pressure ventilation, which we see across the road in the NICU at Mount Sinai Hospital, and which I refer to as Mount Sinai belly. Sometimes there is focal dilatation. As you see, this loop of transverse colon is dilated, and the rectosigmoid is dilated. And I refer to this as flatus about to be released transanally. It's about to be extruded as an FART.
Yeah.
Will people in Nigeria understand that?
Absolutely.
Okay, great. So we're on the same page. This does not mean that the baby is obstructed. So every now and then, when I see a big dilated loop, I often go to the nurse or the residents and doctors who are looking after the patient. I say, did this baby pass gas or stool soon after the X-ray was taken? And that is often what we find happens. Now, not all of the babies will have the loops of bowel, the polygons, so closely related to each other as I've shown you already. Sometimes the bubbles of gas are separated from each other here, and you can see even in this one, they're a bit more separated, which brings me back to the giraffes, because you can get giraffes that have patterns of color that are more separated from each other as you go from left to right. And in fact, the shapes are also changing in this thing. So if you compare the shapes of the color patterns in those three giraffes to the reticulated giraffe, they're certainly very different. And in fact, they're all completely normal. So if you see this sort of pattern where the polygons are not right up against each other, in the past, people used to say, well, this is an example of thickening of the bowel wall, and it means that there's inflammation or ischemia and edema. But that's not the case. If you do ultrasound on these patients, just after the X-ray was done, you may see the bubbles of gas you see here and over here, which are separated from each other by several loops of bowel that are collapsed or filled with a little bit of fluid. And when we looked at these cases in our NICU, we found that the commonest reason for the bubbles being separated like this was intervening collapsed intestine in the vast majority. Sometimes the loops were filled with fluid. Sometimes there was a bit of free fluid between the loops, and wall thickening of the bowel was in fact the least common. So although in my day, I was taught that this represented thickening of the bowel wall. It's not true, since we apply ultrasound in these babies, and we've learned to realize that this still can be within normal limits. So if we look at congenital obstructions, the way to look at the X-ray is to try to determine whether there is a high or a low obstruction based on the gas, the intraluminal gas pattern, and then decide whether the obstruction is complete or partial. Now, the difference between a high and a low obstruction is somewhere in the middle of the small bowel. High obstructions tend to be managed without contrast examinations, whereas low obstructions tend to be managed with a contrast enema of the large bowel. You also want to see if there's any evidence of perforation with free gas or calcification due to meconium peritonitis from perforation antenatally. So this is the most important. Try and determine initially whether it's high or low, because this will direct how the baby is going to be managed. So the highest obstruction of the GI tract in a baby is, of course, in the esophagus, when you get esophageal atresia. And you can see the bit of gas in the pouch of the upper esophagus here with the drainage tube. Most babies with esophageal atresia will have a tracheoesophageal fistula, with the distal esophagus forming the fistula with the trachea. So as these babies breathe or are ventilated, air goes through the fistula and actually fills the bowel, and in fact can make the bowel slightly distended. You can see we're losing the polygon pattern, and some of these loops are starting to get a little bit distended. Also, when you see this possibility of esophageal atresia or tracheoesophageal fistula, you want to look for other associated anomalies. You can see here a butterfly vertebra in the spine, some fusion here of these pedicles over here, and this one has cardiac enlargement due to a VSD and fusion of ribs. So look for the vectoral associations, and also look for complications of the esophageal atresia, which is aspiration, and as you can see, there's some atelectasis in the right upper and lower lobes here. Rarely, the esophageal atresia with the upper pouch, as you see over here magnified, will be associated with no distal fistula, and then the abdomen will be gasless. So a gasless abdomen can be due to esophageal atresia with no fistula. But please remember, it can also be present in patients that are asphyxiated, who are not swallowing, or if they've been given drugs that paralyze them and they can't swallow. Occasionally, you may see it in babies that are vomiting tremendously, and they vomit out all the gas from the stomach, although that's quite rare. So keep these things in mind, but always when you see a gasless abdomen, look for the pouch of the upper esophagus. Lower obstructions that still qualify as high GI obstructions give you a pattern of a single bubble, a double bubble, or a triple or quadruple bubble. And the single bubble is usually due to gastric atresia, the double bubble due to duodenal atresia, and the triple bubble due to jejunal atresia. And again, these patients, you usually do not need to get an upper GI series. You can make the diagnosis based on the gas distribution. Sometimes we see these patients come to our hospital and they have a nasogastric tube with suction on, and they've sucked out all the gas, and it doesn't look like a typical double bubble or single bubble. Instead of using water-soluble contrast, you can just inject some gas to try and distend the upper GI tract, and the gas can act as a type of contrast that will give you the diagnosis. If you use water-soluble contrast with an esophageal atresia or with a gastric atresia, you stand the possibility of having aspiration, as you see over here, into the trachea. And in this one with the stomach, you see lots of gastroesophageal reflux, which can also lead to aspiration. So it's much safer to use air as a simple negative contrast agent to delineate the site of obstruction if the bowel or the esophagus is collapsed. You can see here with this gastric atresia how active the peristaltic activity is in this stomach, and the rest of the abdomen is gasless. You can also use ultrasound, which has been used in recent years to document the fact, say that in a duodenal atresia, the wall will be thickened and hyperechoic due to edema of the wall proximal to the obstruction. And sometimes the gastric wall is also hyperechoic and thickened. So ultrasound can be quite useful in these patients. In this particular patient, you can see there's a double bubble here with a third bubble. So it's stomach, duodenum, but what is this third bubble? So when you think about, could this be a partial duodenal obstruction? You have to start worrying about malrotation. And we did an ultrasound on this patient. You can see the stomach is dilated here, the duodenum is dilated, but then here is the gallbladder. And look, there's gas bubbles in the gallbladder. And that can sometimes happen in duodenal atresia when the sphincter of Oddi becomes dilated because of the pressure antenatally in the duodenum. And once the baby is born, some gas goes up the common bile duct and fills the gallbladder and the biliary tree. So you know from this that this is not going to be necessarily a malrotation. This is just gas in the gallbladder with a duodenal obstruction. The other things to look for on this patient are, first of all, the superior mesenteric artery and vein relationship, because the superior mesenteric artery and vein have a normal relationship here. The vein is anterior and to the right of the artery. So that indicates that it's more likely to be due to normal rotation with an atresia. And secondly, you can see the third part of the duodenum crossing the midline here. You see it over here between these two arrows, between the aorta and the superior mesenteric artery. And that's the normal position of the third part of the duodenum. And you can say fairly confidently that this baby is not malrotated. This is simply a duodenal atresia. In malrotation, the obstruction is in the duodenum, either due to Ladd's bands across the duodenum, and I'll explain that a little bit more in a second, or due to a volvulus. So you would expect that a patient presenting with bilious vomiting due to a malrotation would have a pattern similar to duodenal obstruction, which is a double bubble with no gas beyond, or a double bubble with a little bit of gas beyond. But that's not the case, because sometimes the duodenum in these babies is either collapsed or the duodenum is full of fluid. And when it's full of fluid, you may only see the gas in the stomach, and you may simulate a gastric atresia or a pyloric stenosis with partial obstruction because there's some gas over here. So you have to be very careful in patients that are vomiting bile. Certainly, if these two patients are vomiting bile, the obstruction can't be in the stomach. It has to be beyond the stomach. So you still have to worry about malrotation. In this baby over here, you see the bowel gas pattern is normal, that is vomiting bile. When we did the enema and turned the baby left side down, you can see the gas from the stomach comes into the duodenum, which is dilated and obstructed, and tells you that this is probably due to intermittent distension of the duodenum from a malrotation. So the malrotations can have a variety of abdominal x-rays. and you cannot make the diagnosis and you cannot exclude the diagnosis of malrotation based simply on the X-ray. If you think that the baby has malrotation due to the presence of bilious vomiting, one has to go on to something else, like an upper GI series or an ultrasound, in order to confirm or exclude the diagnosis. And one has to do that quickly. That's an acute thing. So in the upper GI series, we are looking for the position of the duodenum, and the normally rotated duodenum has the duodenojejunal flexure in the left upper quadrant at the same level as the duodenal cap. Now that used to be the mantra that was stated, that it always had to be there, but in truth, it's not always to the left of the spine. Sometimes it's on the spine, and sometimes a little lower. But the point is that you come around to the fourth part, which then goes up. Normal proximal jejunum is on the left. You have to have your images, these two images, taken absolutely straight. The patient cannot be rotated. And sometimes with little babies, it's difficult to know at one end of the baby or the other end of the baby whether they are rotated, because little babies have such flexible bodies that you might be holding, as a radiologist, you may be holding the legs, and the legs may look straight to you, but meanwhile, the upper part of the body is turned. And when the upper part of the body is turned, you may have the duodenum in a funny position, which may mislead you into the diagnosis of malrotation. So it's important to look at these patients absolutely straight. In malrotation, the proximal duodenum and jejunum can be on the right, or they can come down the midline, which I find is the most commonest, or they can actually cross to the left but be low. So there's absence of that fourth part of the duodenum going up. And this shows why on the upper GI series, there is such a variety of positions of the duodenum in malrotation. I'm going back to the normal. This is the normal, always going over to the left. Proximal jejunum is in the left upper quadrant, but in malrotation, the duodenum and proximal jejunum can either be on the right, down the midline, or low on the left. Here is an upper GI where you see the abdomen has got a completely benign looking, non-obstructive appearance, and yet the baby is vomiting bile. Contrast injected comes through into the duodenum, not dilated, and slowly as more comes in, it gets more dilated, emphasizing that the duodenal dilatation is intermittent. Here it comes to a complete halt, where the Ladd's bands are obstructing the duodenum and then starts to trickle through. And as it trickles through, it's on the right side, and the duodenum becomes less distended again. So duodenal distension is intermittent, and eventually it gets through and it's on the right and not on the left. If there's a volvulus as the cause of the obstruction, the typical findings on the upper GI are a beak sign that you see over here, and then the corkscrew sign of the volvulus as the contrast goes through the loops that are actually volved. In this one, you don't see the beak, but you do see the corkscrew sign of the narrowed bowel as the contrast gets through it. Notice that in these, both of these images are taken with the vertebrae showing that the patient is in a lateral view. So it's important not only to take an absolutely straight AP view to look for the DJ flexure, it's also important to take a lateral view to look at the character of the duodenum, because I think these corkscrew signs and the beak signs are more easily visualized when you're looking at the baby laterally. Now, as I said earlier, in more recent years, ultrasound has come to play a very major role in many areas in pediatric imaging, but it's slowly become, we've come to understand that it can offer us important information, even in GI abnormalities such as malrotation. And the most important thing to know, and this applies to CT and MR as well, is the whirlpool sign of the volvulus that we see on ultrasound, and which is very easy to diagnose and can be quickly diagnosed on ultrasound, and I think has less false positives and negatives than the upper GI series in these babies, and I think has really taken over from the upper GI as the imaging modality of choice. Now, let me just go over the embryology of malrotation before I show you the ultrasound images. Remember that the midgut, which is on a base of or an axis of the superior mesenteric artery, herniates into the umbilicus in the first trimester. It rotates anti-clockwise, and then it comes back into the abdomen, firstly the small bowel, and then the large bowel. And the cecum is initially high, and then it grows down into the right lower. This video. So this is a video of a diagram of the midgut as it's going to herniate into the umbilical cord, which is here, rotate, and then come back in a normal rotation. So it comes out, rotates, grows along, and then comes back in, first the small bowel, to form a normal duodenojejunal junction, and then the cecum is here, so the width of the mesentery is wide. Here it comes out, I play it again, it comes out, grows very long, then comes back in, first the small bowel with a normal DJ flexure and a normal cecum, so the base of the mesentery is very long. In malrotation, the small bowel comes out, grows, comes back, but the small bowel here is in the midline. There's no DJ flexure, and the cecum is close to the duodenum. And because the cecum is close to the duodenum, there are bands across here, which are Ladd's bands, which can obstruct the duodenum, as I showed you in the upper GI images. But worse than that is that the base of the mesentery is extremely short here, because you don't have a DJ flexure and you don't have the ileocecal valve down here. So the base of the mesentery is very short, and therefore the small bowel can undergo a volvulus. So here is what a volvulus looks like on ultrasound. These are transverse images of the upper abdomen. This is the spine at the back and the aorta. And usually you see the mass of the volvulus immediately anterior to the aorta and IVC. And you see it as almost as a target sign, with the superior mesenteric artery in the center and the veins going around, forming this whirlpool on color Doppler. In this one, you've got the same thing. Here is the whirlpool, which you can see on the color Doppler. The veins are going around and the artery is in the center, and I'll show that to you better on the next one. But here is the dilated duodenum coming to that beak that I showed you on the upper GI series. So you've got the obstruction in the region of the duodenum. It comes to the beak that you see on the upper GI, and then you get the volvulus, so well shown and very easy to see on ultrasound, because this volvulus is immediately deep to the anterior abdominal wall. You don't have to go searching for it. It's usually in the midline, or sometimes to the right, or sometimes to the left of the midline, but it's quite easily visible. On video, you will see here the superior mesenteric vessels are inverted. And then as we go down, you'll see the coil of that volvulus. And then coming back, you see the coil again. And you can see it on grayscale. You don't have to have Doppler. I just want to go back to the beginning again to show you the superior mesenteric vessels are inverted. The vein is to the left of the artery, which is in the center. If we look at it on color Doppler, you'll see the whirlpool of the vessels of the veins going around. That's all the way down, and then coming back up, you see the artery is in the center and comes back to the aorta. So these are easy diagnoses because the mass, as I've shown, is just immediately deep to the abdominal wall. Between the abdominal wall and the aorta and the IVC, it's usually in the midline, can sometimes be to the right or left, and it's in a transverse plane. So you want to diagnose it as shown over here with the transducer lying transversely across. In this one, you see here's the spine. It's a transverse view of the abdomen. Here's the abdominal wall. Here's the spine, aorta, IVC. Here are the superior mesenteric vessels, the artery and the vein, which are inverted because the vein is to the left of the artery, and the bowel comes in front of these vessels. If you remember the ultrasound I showed you of the duodenal atresia, the normal position of the duodenum is to go here between the aorta and the superior mesenteric artery, should be behind. Here it comes in front, and as I run the video, you'll see this go to this left side, and the volvulus is over here on the left. You can see the volvulus in grayscale. You don't have to have Doppler. I'll just play that again. Goes in front of the vessels to the left, and it turns around there. So if you don't see the volvulus in the midline, immediately deep to the abdominal wall, one has to look to the right and left to see if there's any abnormality there. Now, here is a very instructional case, especially for our department. This was a baby, a newborn baby who came in one night with bilious vomiting. You can see the x-ray that we got shows a bigger problem. This is the x-ray from the referring hospital. It's got a double bubble, big stomach and big duodenum, but there's a little bit of gas beyond, so it's not a duodenal atresia. It could be a duodenal stenosis, but duodenal stenosis as such is very rare to present in the neonate. The thing to think of here obviously is malrotation with obstruction of the duodenum, either due to the Ladd's bands or due to the volvulus. When the baby came to us, the NG tube had been put in and it sucked out a lot of the gas from the stomach and duodenum. And in fact, the bowel gas pattern distally looks completely normal. So if you want to prove that it's a double bubble, you'd have to inject some gas in here simply. There had been an ultrasound done at the referring hospital, which was said to be normal. So the neonatologist asked our department to do an upper GI that night, and they injected some contrast into this big stomach, which fills the dilated duodenum, which has a very sharp ending on the AP view and a sharp ending on the lateral. So it was said to the clinicians that this probably is due to a stenosis or a web, and we don't have any evidence of a volvulus, because with a volvulus you expect to see a beak. Round about the time that this decision was being made, the ultrasound from the referring hospital turned up in our hospital, and everybody took a look at it. And what it shows is this big dilated duodenum here. This is the spine. Here's the dilated duodenum coming to a beak. And then you've got this mass in front shown by the arrows, which has the whirlpool sign of a volvulus. And I think this is a good example how at the referring hospital, where they were not used to seeing a volvulus or recognizing it, they said there was no evidence of volvulus. Whereas at our hospital where we did the GI, we said there's no volvulus here. And yet when you look at the ultrasound, there is a volvulus which they missed, and in fact, which our upper GI was misleading. So we believe today that the ultrasound is a better way to look for volvulus than using an upper GI series. And it's certainly, I think, a lot easier to do than fiddling around with an upper GI with contrast into various positions for a baby that can sometimes be quite ill. Now, we've talked about the upper or high obstructions of the GI tract. Now I'll talk quickly about the low obstructions of the GI tract. And by low, I mean everything beyond roughly the region of the mid-small bowel. Now, when there's an obstruction that is more distal, the appearances do not have typical findings like you'd see with a single, double, or triple bubble of the high obstructions. These often look very similar. And in this one, you can see there is diffuse distension of bowel. We've lost the giraffe pattern, and the bowel loops are not polygons now. They're more rounded loops or elongated loops. And in the upright view, this is an old film with the baby is actually upright, you can see there are sharp air fluid levels. Today, we wouldn't do an upright view like this. We just do a lateral shoot through, and you'd see the fluid levels as well. In this one, there is diffuse distension again. You can see the loops are elongated. You don't see as many round loops, but there's one loop over here that is much larger than all the other loops. And in this one loop, with this baby in the lateral decubitus position, the left lateral decubitus position, you see very sharp air fluid levels. Another one with diffuse distension, with one loop bigger than the others. And you can see it over here, this big loop with a very sharp air fluid level. So these two X-rays look different to this because this one has diffuse distension, while these two have one loop that is bigger than the others, but a very sharp air fluid level. In the last one I'll show you, you see diffuse distension. We've lost the polygon pattern, and there's one loop over here that does not have very nice, sharp air fluid levels. So it's a little different to this one where there's a very well-defined air fluid level. This one doesn't have that. These findings, I've said, are more non-specific than in the high obstructions, but there are some ways you can use them to help you. I find that the babies that have diffuse distension with air fluid levels either have Hirschsprung's disease or functional immaturity of the large bowel. The ones that have a focal loop that's much bigger than the others with an air fluid level are usually the atresias and the anorectal malformations. If you have a focal loop that's bigger than the others but lacking an air fluid level, it's most likely due to meconium ileus. And it's said that you don't get the sharp air fluid level in meconium ileus because the meconium is so thick in these patients with cystic fibrosis. So I find that this is helpful to guide me in whatever direction I think the baby may be ultimately diagnosed with. There are other things that one should look at or ask the clinician about before doing the enema. And you want to know about gestational age. It's more likely to be Hirschsprung's if it's a mature, a full-term or post-mature baby. It's more likely to be functional immaturity if it's a premature baby. Sex, it's more likely to be Hirschsprung's if it's a male, although females have a higher incidence of genetic hereditary Hirschsprung's. You want to know the family history. Is there a family history of Hirschsprung's or of cystic fibrosis? You want to know the mother's history. Is the mother diabetic? Because then there's an increased incidence of functional immaturity, even in full-term babies. Some races do not have the same incidence of cystic fibrosis as others. Trisomy 21 has a higher incidence of Hirschsprung's. And then, of course, you want to know the physical examination. Did the clinicians actually examine the anorectal area, because to make sure that there's no anorectal malformation? So the 5 diagnoses that you think of in these patients are firstly atresias of the small or large bowel, Hirschsprung's disease, functional immaturity, cystic fibrosis, and stenoses. Then you get on with doing the enema. And here is an example of Hirschsprung's disease with a narrow rectosigmoid and a transition zone in the mid-sigmoid region with proximal dilatation. Similar thing here, narrowed rectum and a marked transition zone in the rectosigmoid junction area. This is the classical description of Hirschsprung's, but many babies will not have that classical appearance of Hirschsprung's. And sometimes you'll just find a whole lot of plugs in the large bowel, as you see here, but no definite site of a transition zone. It may be up here. And in the post-evac film, the baby has got rid of everything. So the old way of doing things by getting a 24-hour film is usually a bit of a waste of time. And it's not very helpful. Remember, Hirschsprung's disease ultimately is a biopsy diagnosis, so that even if you get an enema that is not typical of Hirschsprung's disease and the baby continues to be sick, it's important for the surgeon to go ahead and get a biopsy on these patients. Here is a baby with a small rectosigmoid region and descending colon and a transition zone at the splenic flexure. This baby is premature, and Hirschsprung's disease is much less likely in premature babies. After we did the enema, he got rid of this plug. He evacuated this long plug of meconium, which you can see correlates with a small distal colon and a caliber change at the splenic flexure region. And because this is a premature baby, one would not do a biopsy, and one would accept this as a functional immaturity and see how the baby does. And usually they do well once they've got rid of the plug and they start maturing. Other things what might find in an enema is a microcolon with a complete obstruction here in the descending colon. This is a baby with an atresia of the colon. I show this not only for that, but also to show you this great big balloon that has been blown up in the baby's rectum. Don't blow up balloons to this size in babies' rectums, because you can cause some damage, and you can actually perforate the rectum with a balloon this size. Either don't use a balloon at all, or just blow it up to a very small volume. Make use of taping the buttocks tightly and even squeezing the buttocks in order to keep the contrast inside, but don't rely on a balloon of this size. Here's another atresia of the large bowel, this time in the proximal transverse colon. You can see the microdistal colon here coming around this corner in the transverse colon, and then the small gap in the mesentery, and here's the dilated proximal colon. In this one, there's a microcolon with a cecum here, and the terminal ileum is filled with plugs, which is classic of cystic fibrosis, and these big dilated loops proximal to that. Here's another one with cystic fibrosis with lots of plugs in the small bowel. And in this bowel one, we've been able to get it back along the small bowel. There are no plugs here, and we land up at this blind ending part of the terminal ileum, which is an ileal atresia, and you can see the dilated bowel proximal to this. So there are multiple things that one can see on the enemas in these children. Sometimes you can make the diagnosis with absolute certainty, but that's not always the case. And if you don't come up with an absolute diagnosis, you have to consult with the clinicians, particularly the surgeons, as to whether they should do a biopsy to exclude Hirschsprung's disease. This is the patient with cystic fibrosis. You see the dilated bowel proximal to the plugging in here. You can see the beaded appearance. When you open the bowel, you see this very black, thick meconium, which won't form that nice air fluid level. And that's the reason why the bowel is black. It's not poorly perfused. You can see there's a lot of blood in these vessels. It's the intraluminal content that makes it look black. Distal obstruction, where you've got a lot of dilated bowel, you've lost the mosaic pattern or the giraffe pattern or the polygon pattern, and the loops are looking elongated. This pattern is not only due to distal bowel obstruction. There's some differentials you have to keep in mind. One is simple ileus due to sepsis or electrolyte imbalance. I find they're the two most common, particularly sepsis. They can look like this. If you have malrotation and a volvulus, and the bowel is ischemic, very badly ischemic, they will not just present as a duodenal obstruction, they'll present with the ileus due to the ischemia, and they may look like this as well. And lastly, in hypothyroidism, they can sometimes look like this. So it's important to keep hypothyroidism in mind, although with testing in the neonatal period, we don't tend to see these anymore getting this bad. But please keep that in mind as a differential. One other pitfall with distal obstruction is they don't always have lots of gas in the abdomen. The vast majority of them will have a lot of gas in the abdomen, but every now and then you can have a distal obstruction in a patient who only exhibits a small amount of gas. So you might say that this baby has a jejunal atresia, because you've got the stomach, the duodenum, and just a little bit of jejunum. You could say there's atresia of the jejunum. But the thing to look at as well is the size of the abdomen. This baby has a huge abdomen. So if we are dealing with an obstruction in the jejunum shouldn't give you such a big abdomen. Is there ascites here? Does this patient have polycystic kidney disease with massive kidneys causing the entire abdomen to distend like this? You don't know. It's very, very easy in these patients to put an ultrasound probe on them and to see today exactly what the cause of the massive distension is. Now, in this particular baby, which I'm going to show you because I think it's a very good teaching case, one of my fellows, when I was training here many, many years ago, came to me one morning and said, I had an interesting case last night. The baby was obstructed. I put a catheter in the rectum, and when I was filling up the colon with contrast, the baby kept evacuating the contrast. I couldn't keep it in. And we were holding the baby's buttocks, and we taped the buttocks, and it was 2 o'clock in the morning, and I had to do this thing quickly. So I put the catheter further up into the bowel, and I thought, no, it's not a good idea to put the catheter too far up in the bowel. You should just keep it in the rectum. And he then said, I blew up the balloon to 5 cc's. And I thought, no, not a good idea to blow up a balloon in a baby's rectum. And he said, then I started to fill, and I found that there was a microcolon, and I got back into these loops of ileum here that had plugs. So I thought I was dealing with the meconium ileus, and I wanted to get the contrast proximal to the plugs so I could get out all the plugs. And suddenly there was a perforation, and all of this contrast went out into the peritoneal cavity. Now, what this shows you in this case is what's the cause for this massive distension. It's not ascites, it's not a great big mass. It's huge loops of bowel that are filled with fluid. You can see it very easily if you do it today with an ultrasound. You don't have to perforate the bowel to see it. But here you can see the example of the perforation showing you these huge loops of bowel that are simply filled with fluid. So several things to learn from this case. Number one is that a distal obstruction sometimes may have only a small amount of gas present. But the key, the clue, is the size of the abdomen. Because there's got to be something making this abdomen big, and it's distal bowel filled with fluid. So you want to know, is it the big, large loops filled with fluid? Is it ascites or is it a mass? Today, the easiest thing to do is an ultrasound, but I show you this because perforation of the bowel can occur if you put the catheter too high, you blow up the balloon too big, and you use too much pressure to try to get the gas, the contrast too far proximally. And in this patient, the fellow that did it one night perforated the sigmoid colon. So now it's 7 minutes past 3, Rotimi. I think
how many slides do you have left?
Oh, I have hundreds of slides left. It's up to you.
Well, I think what we will do, I think we might need to make this a 2-part series. Let me just, how do I get this here? I want to end this here. We might need to make this a 2-part series, just for the sake of time. Dr. Elanisi, Professor Talabi, what do you think about that? Because, okay, I'm getting a thumbs up there because I think it's very useful information, and, you know, Dr. Dannemann has been doing this for decades now, so to get his expertise on the matter is certainly will be vital. So if I have the permission of Professor Talabi, who is our pioneer president, and the other leaders in the house, like Dr. Professor Italy is online as well, we can make this a 2-part series if that's okay with you. And I know the Euro final has started, so some people want to know watch ball as well. By the way, Dr. Dannemann is also a very avid football fan.
But thank you, Rotimi. You could see that people are still logged in, even despite the cup. But then, I think we need to actually have him to come back. This is so much to learn, you know, that we need to make this a 2-part lecture. And then also Spain, before the next one, we must have found a way to increase the participants from this 100 to so much, because we really, really need to have our audience in. So, well, the president, Dr. Ilalusi, what do you think?
Yes, I think we have to do that. Yeah, we have to increase the capacity, but we wanted to do that. It's just that Zoom made it difficult because, I mean, they told you that there's a plan that you bought that didn't allow for upgrade. I really wonder what they meant by that. And I think it was